Very good morning to all of you. I welcome Honorable Emeritus Chairperson M.L. Swankar sir, Chancellor Gulati sir, Principal and Controller Andisoni sir, Medical Director Jaiswal sir, and all dignitaries in the hall, my seniors, my colleagues, and dear students. I welcome all of you in the combined clinical round of Pediatric Cardiology. Our department is new to the organization. We start functioning since April 2024, this year. Welcome, Kapoor sir. So it is headed by Dr. Sunil Kaushal sir, which is Director and HOD, CTVS Surgeon, me, Dr. Sanjay Khatri, and my colleague, Dr. Kanupriya, is Pediatric Cardiologist. Yes, we are functioning in the annex tower, ground floor. We have a Department of Pediatric Cardiac Sciences. Pediatric Cardiology is functioning in the institute previously also, but it's a division of adult cardiology. But now, since April, we are grateful to organization to give us that opportunity to establish the full-fledged unit of pediatric cardiology and doing all type of pediatric cardiac work. Thankful for providing us high-quality echo machine, that is Philips Epic CVXI, in which there is a neonatal probe, pediatric probe, adult probe, fetal echo probe, and 3D probes. By that, we can reconstruct all the images that help us in the diagnosis, intervention, and surgical decision. It is the best quality machine available in the state. The field of pediatric cardiology involves evaluation of congenital heart disease through echocardiography, neonatal and pediatric cardiac interventions for congenital heart disease, which we are doing in our cath lab, fetal echocardiography for detection of congenital heart disease in utero, in fetus, that is our case, managing and stabilizing the sick cardiac patient with the help of PICU and NICU team, patient of myocarditis, rhythm disorder, deeply cyanosis, we are managing with the help of PICU and NICU team. And adult congenital heart disease, yes, the patient who are operated in late 90s now presented to us. The patient who are missed that time, ASD, VSD, TOP, they are grown up adults, but they come in our domain, they come in the umbrella of pediatric cardiologists. So department workflow, 2500 echo done over 8 months, which include esophageal echo and fetal echo also. This is the statistical analysis of various echo. As you see, numbers are increasing because previously we are doing our echo with the sharing of adult machine, that SRC building ground 1. Now we have our dedicated echo machine, so that number will definitely going to increase. Cardiac catheterization, close to 75 cardiac catheterization over last 8 months, range from 2 days to 48 years. Yes, we are tackling the newborn and 48 years, the grown-up adults who have congenital heart disease come under our domain. So we have done all type of intervention, whether device closure, balloon dilatation, coiling, stenting, all we have done. We put our presence in various conferences, whether it's international, national or state level, international at San Diego, state level and national level in PCSI Kochi, and state level at Bikaner and Jaipur. We mark our presence in all these conferences. 1 publication since April and 3 articles under review. Yes, we are new to organization, but promise more publication, more good cases will be there. A miles to go, we are new to this organization. And one thing I will say, we are very happy to working at every minute in this institute, whether it's a clinical, academic, or working in the cath lab. We delight to work in this institute, and thanks to Swankar sir to give us opportunity to establish pediatric cardiac unit here. So, this is our case, a case of fetal tachyarrhythmia, antenatal to postnatal management. I invite Dr. Ayushi to initiate the case.
Good morning, everyone. My name is Dr. Ayushi Agarwal. I'm junior resident in the Department of Pediatrics, and under the guidance of Dr. Sanjay Khatri sir, I'll be presenting the CCR on the topic of a case of fetal tachyarrhythmia, antenatal to postnatal management. Our case starts as a 25-year-old pregnant female, homemaker by occupation, presented for evaluation after an abnormal antenatal scan. The scan was suggestive of fetal heart rate of 200 to 220 beats per minute. The patient also has history of 2 prior missed abortions, both at 16 to 18 weeks. The antenatal scans done during both these previous pregnancies was at 8 weeks, which was reported normal. No further scans or investigations were done, so the cause of these abortions was unknown. For the current pregnancy, it was a spontaneous conception. The fetal well-being scan was done at 6 weeks of age. The mother blood group was AB negative. The husband blood group was B positive. The ICT test and the torch profile were negative as well. Since it was a precious pregnancy and the parents were anxious, frequent scans were being done. Scans done at 14 weeks, 18 weeks and 24 weeks were all reported normal. But the fetal well-being scan done at 26 to 28 weeks was suggestive of fetal tachycardia. This is a fetal echocardiogram showing 4-chamber view, and here we can see that there is presence of LV dysfunction along with abnormal rhythm. This is a fetal echocardiogram showing normal contractility of the heart and the normal rhythm. And to compare, we have our patient's fetal echocardiogram showing poor contractility and abnormal rhythm. The fetal heart rate on the Doppler was around 224 beats per minute. The mean fetal heart rates in normal subjects in the first trimester is about 152 beats per minute, in the second trimester is 146 beats per minute, and in the third trimester is 143 beats per minute. Our patient being in the third trimester had a fetal heart rate of 224 beats per minute. So we come to an initial diagnosis of fetal tachyarrhythmia with severe left ventricular dysfunction. Now the question in front of us is which type of arrhythmia? Because the further management depends upon the type of arrhythmia, whether it's a supraventricular type of arrhythmia or a ventricular type of arrhythmia, and whether it's associated with signs of hydrops. This here we can see the white arrows denote the atrial rate and the ventricular rate is denoted by the V. We can appreciate the fact that the atrial rate is almost the double of that of ventricular rate. The atrial rate is approximately 450 beats per minute and the ventricular rate is 224 beats per minute. So we know that it's an atrial tachycardia. So here also on the M mode, to further confirm, we see the red arrows denoting the atrial contractions and the yellow arrows denoting the ventricular contractions. Here also we can see that the atrial rate is much higher than that of the ventricular rate, further confirming our diagnosis of atrial tachycardia, most likely atrial flutter. So to summarize the case, up till now we have a 28 weeks pregnant female with a fetal heart rate of 224 beats per minute with severe LV dysfunction, no signs of pericardial effusion or atrioventricular valve regurgitation. So we start our management antenatally at 28 weeks of gestation. We start the patient on tablet sotalol at dose of 160 milligrams twice daily, and the patient is advised to revisit us after 3 to 5 days. At 29 weeks of gestational age, the patient is reassessed. This is the fetal echo showing the of the patient. We can see the LV dysfunction is persistent and the rhythm is still abnormal. The fetal heart rate is approximately 200 beats per minute. There is no signs of pericardial effusion. There is no presence of MR or TR, so we know the patient is not in hydrops. So we realize that there is poor response to a single antiarrhythmic drug, so a second antiarrhythmic drug is added. Digoxin is added and it's given at a dose of 250 micrograms twice daily for 3 days, followed by 250 micrograms once daily. The patient is advised admission for continuous monitoring of fetal heart rate, but the patient wants to continue the management at home and requests us. So the case is discussed with neonatology and our obstetrics team for further care. At 30 weeks of gestational age, the patient is reassessed. LV dysfunction is still persistent. Abnormal rhythm is seen. The fetal heart rate is approximately 190 beats per minute. There are no signs of hydrops. There is no pericardial effusion, no MR or TR. So we realize that there is still not adequate response to dual antiarrhythmic therapy. So a third antiarrhythmic drug is added, that is tablet flecainide at the dose of 50 milligram twice daily. So we realize that even after adding 3 antiarrhythmic drugs, there is still poor response. So now I invite Dr. Sanjay Khatri sir to take the case forward.
So summary: fetal tachycardia, atrial flutter diagnosed at 28 weeks of gestation. Fetus is having severe LV dysfunction. 2 unexplained abortion during second trimester is in our mind, because at that time they lost, no investigation were done. Third time we luckily diagnosed this. We don't know the cause of previous 2 abortions. started on triple antiarrhythmic medication, sotalol, digoxin and flecainide, as sir mentioned. Yeah, these drugs we are giving to the mother. They are very well lipophilic drugs. They very well cross the placenta, and even literature says sotalol and flecainide level is comparable in fetus and mother both. They are very well traverse the placenta. So we have a 30-week pregnancy. Fetus contractility is very poor. 2 unexplained abortions. This time this also happened. Risk explained to family. So whether we can deliver the baby is 30 weeker. Can we deliver? Then there is a risk of prematurity. If we continue, there is always a risk, because previous 2 pregnancy we have not have wanted result. So what we will do? Everything discussed with the family. Mother ECG every 3rd day, as sir mentioned. Yes, these drugs have some adverse effect in mother ECG also. Their PR is prolonged, QTC gets shortened, or prolonged. So we have close watch on mother ECG every 3rd day. Fetal heart rate monitoring every alternate day, because we know these 2 weeks are crucial. If we cross 32 weeks, we prevent most of the complication of prematurity. Simultaneously, this is the risk, because we have done maximum for our side. 3 antiarrhythmic we have already added. Plan for LACS within 2 weeks. So this is 32 weeks, still no response. You find heart rate is still abnormal, rhythm abnormal, contractility is poor. But this time fetal heart rate is 181. So 32 gestation, still no signs of hydrops, means there is no collection around the heart, no AV valve regurgitation, we find no collection around lungs, no ascites is there. So what is this? Treatment failure. Yes. What we can do? A pregnant lady with 2-year abortion, what we can do maximum? We start pharmacotherapy treatment. But all these things we are doing with the guideline, AHA guideline, American Heart Association guideline, March 2024. So if you find any fetus with tachyarrhythmia, first management is always pharmacotherapy and close monitoring, whether it's a hydrops or not hydrops. In our case, atrial flutter is there, but there is no hydrops. That is the good sign. We can buy the time. If hydrops is there, still guideline says you first continue the pharmacotherapy with the close monitoring. Don't jump to deliver the baby soon, because then you caught in other complication of prematurity. Everything is our control. Mother heart rate we are monitoring, mother ECG we are monitoring, and we are building on pharmacotherapy. Then first drug we started sotalol. It's now the recommended drug. I can say 60% of atrial flutter respond to sotalol within 7 days. So heart rate will be normal. But we are unfortunate. This is not happen in our case. Then we add second line drug, that is digoxin. Then no conversion still. Then we add third drug, flecainide. Yes, mother is taking all these drugs regularly. There is no guideline to recommended the drug level of flecainide and sotalol, because they are very lipophilic drugs. They are same in the mother level and the fetal level. Few guidelines say you can monitor the level of digoxin, or you can follow with ECG. We are regularly doing the ECG, but we are still having fetal tachycardia persisting. So it's a treatment failure, or correct word would be we are not getting the desired response or adequate response which we are expecting to get as per guidelines. And in our back of the mind, 2 abortions are there. So, but still we not lost all the things. Some positive points still there. What are those positive points? Fetal heart rate in initial, what Dr. Ayushi shows, it's 224 or 220. Now it is 181. At least we achieve something to bring down the ventricular rate, but flutter is still persisting. No evidence of pericardial effusion or AV valve regurgitation, no collection of fluid in any cavity of the fetus, means what we achieve, we prevent the fetus to being hydrops. Fetus is not hydrops, it's still alive with the 32 week with a heart rate of 180. Possible some buildup of level of antiarrhythmic in the fetus also, because we are giving the drug to the mother since last 4 weeks. That drugs are very well cross the placenta, so we assume fetus will have some level of antiarrhythmic drug in his blood that will help us in our further management. And above all, mother is the prime care. No side effect in the mother noted. No unexplained vomiting, no nausea, no pain abdomen, no blurring of vision, no ECG changes. We watched for all the changes of ECG, what digoxin and flecainide can cause. We monitor the mother very carefully. No side effect in the mother. Yes, Pharmacotherapy is not work in our case, but these are the positive points. We have still fetus alive at 32 weeks. Family still hopeful, which was not there in previous 2 pregnancy, and I am with my team. Ops and neonatology are ready to take care of the baby. So our aim to catch the baby up to 32 weeks, which we are successfully done. Yes.
Sir, one question. What is the downside of fetal tachycardia? Like one could be spontaneous abortion. What are the other downsides?
For any fetal tachycardia, there is a poor contractility of the heart. So filling pressure of the filling time is reduced. So patient is going to LV failure and hydrops will be there. Hydrops is manifest in the form of collection of fluid in the ascites, pleural effusion or pericardial effusion. AV wall regurgitation started. In our few cases which are supraventricular tachycardia, patient comes with hydrops. We started pharmacotherapy and after 7 days what we are seeing, in between rhythm is getting regular. So hydrops, pericardial effusion is getting decreased by pharmacotherapy. But we are very unfortunate in this case. We are not able to terminate the rhythm, but we are able to prevent the fetus is going into hydrops. I discussed the case with Jaya madam. She listened to me very patiently at the 3 o'clock in the so what final statement she told me, we will give you baby tomorrow early morning. That is so reassurance for me that we are in the safe hand, family is in the safe hand. So now over to Yukti to take case further.
Good morning, respected teachers. I, Dr. Yukti Parekh. Good morning, respected teachers. I, Dr. Yukti Parekh, second year PG resident from Department of Ops and Gynae. I am here to present a case of Mrs. X, 25-year Hindu female, homemaker, resident of Dungargarh, referred to antenatal OPD with amenorrhea of 8 months in view of abnormal fetal echo. Her Hobbs history is, she is gravida 3, abortion 2. First was a missed abortion at 16 weeks, which is followed by dilatation and evacuation 2.5 years ago. Second was also a missed abortion at 18 weeks, which was also followed by dilatation and evacuation 1 year ago. Third pregnancy is a spontaneous conception 1. In first trimester, the pregnancy is a spontaneous conception. USG fetal well-being was done at 6 weeks, which found to be normal. Patient blood group is AB negative. Husband blood group is B positive. Indirect Coombs test was done, which is negative, as mentioned above. Rest all the routine antenatal investigation which was done are normal. Double markers which shows beta HCG and pregnancy associated plasma protein A, which was done, which is also negative. The anomaly scan done at 20 weeks, which shows no gross congenital anomalies and the normal color flow. The scan was done at 28 weeks. All the parameters of the scan was normal, except fetal heart rate, which show fetal tachycardia, which can be a sign of any tachyarrhythmias. The growth scan done on 33 weeks plus 3 days, which shows single live fetus of around 33 weeks plus 2 days. Placenta was anterior and upper. Amniotic fluid index was around 20 centimeter. The weight of the baby was around 2.1 kg. On further history taking, there was no history of any teratogenic drug intake. Patient was already on tablets sotalol 160 mg twice a day from 28 weeks of period of gestation. Patient was on tablet digoxin 0.25 mg from 29 weeks of POG and tablet flecainide 50 mg BD since 30 weeks of POG. A menstrual history was the last menstrual period on 21st January 2024. Expected date of delivery is 28th October 2024. The previous cycle was regular. The period of gestation at which she was referred to us is 33 weeks plus 3 days. There was no significant medical and surgical history. There was no significant family history of heart disease, diabetes mellitus, hypertension and TB in family. On general physical examination, the patient was conscious, well oriented to time, place and person. The pulse was 80 per minute, which was regular. The BP was 136 by 80 mmHg, which is taken in right arm in sitting position. Temperature was afebrile. The BMI was 27 kg per meter square. There was no pallor, icterus, cyanosis and clubbing. The hair, skin and nails were normal. Bilateral breath was soft. Normal changes of pregnancy. No palpable mass. No lymphadenopathy. No pedal edema. On respiratory examination, bilateral air entry was present. Lung field was clear. On CVS examination, S1 and S2 was normal. Regular heart rate. No additional sound heard. On per abdominal examination, uterus was around 32 to 34 week size, cephalic presentation, head was floating, uterus was relaxed. Fetal heart sound on Doppler was around 200 beats per minute. As we can see, as we know, there is a fetal tachycardia and left ventricular dysfunction in the fetal echo and antenatal scan. The decision was taken to terminate the pregnancy the next day after the steroid coverage. Elective lower segment cesarean section was done. At 33 weeks plus 4 days, delivered a male child of around 2.3 kg. Baby handed over to neonatology for further management. Surgery and post-operative state was uneventful. Injection entity received as baby blood group was B positive. Thank you so much. Now I would like to call upon Dr. Shaleen to tell us how they manage the baby in the neonatal period.
Good morning everyone. I am Dr. Shaleen Parmar, DM Neonatology Resident. I will be presenting NICU management of this baby. As there was history of 2 previous abortion and during fetal scan, left ejection fraction was decreased, we anticipated that baby might fall into circulatory collapse. So we were ready with 2 neonatologists and all the equipments necessary for resuscitation. Fortunately, baby cried immediately after birth with Apgar score of 6 at 1 minute and of 8 at 5 minutes. Baby's birth weight was 2.3 kg. That is definitely low birth weight, but it is appropriate for gestation age 33. Baby was having mild subcostal and intercostal retractions with grunting. On auscultation, heart rate was 195 beats per minute and no obvious congenital anomaly noted. For this, baby was immediately shifted to NICU in view of hemodynamic instability, respiratory distress, tachyarrhythmia, and there was need for continuous monitoring and advanced therapies. On initial vital assessment, the core axillary temperature was 36.6 degrees, that is normal. The heart rate was 200 beats per minute, which was irregular. Respiratory rate was 66 per minute. Normal newborn respiratory rate is 40 to 60 per minute. It suggests baby is in mild respiratory distress. Oxygen saturation was 87% on room air. It was suggestive of mild hypoxemia. Non-invasive blood pressure was normal as per age-specific normogram. Baby was euglycemic with capillary blood sugar of 101 mg per deciliter. Proceeding further examination, baby was pink in color with dusky periphery. Baby was having spontaneous movements. The capillary refilling time was prolonged up to 5 seconds. It indicates baby is in the tissue hypoperfusion. It is an initial sign of shock. Fontanelles were at level, no caput succedaneum or any birth injuries. Coming to systemic examination, respiratory assessment done. Signs of respiratory distress were present. Baby was tachypneic with RR of more than 65. Grunting was present with nasal flaring. Retractions were present in both subcostal and intercostal region. This is Silverman-Anderson scoring system. This scoring system is used to assess respiratory distress in preterm newborn. According to this score, 6 out of 10 score indicates baby is in moderate respiratory distress. For that, immediately non-invasive ventilation was initiated. On auscultation, breath sounds were bilaterally equal. Coming to further systemic examination, S1 and S2 was normal with soft systolic murmur. Central pulses were well felt, but peripheral pulses were feeble. Perfusion was delayed with capillary refilling time of 5 seconds, indicate poor circulation. Liver was pushed down 3 cm below right costal margin due to congestive cardiac failure. Neurological systemic examination was normal. At 15 minutes of age, arterial blood gas was done, suggestive of pH of 7.28, which indicates acidosis. Bicarb was 17 millimole per liter, which indicates baby is in metabolic acidosis with lactate of 7 millimole per liter, which indicates tissue hypoperfusion. Bedside screening 2D echocardiography done in view of left ventricular dysfunction and to rule out any structural heart defect. Echocardiography showed ASD of 7 mm, PDA of 2 mm, both were showing left to right shunting. There was significant left ventricular dysfunction with ejection fraction of only 10 to 15%. Mild TR and MR was present. Abnormal heart fast rate noted at 190 beats per minute. Surface ECG done using 3 leads showing irregular fast heart rate of 190 beats per minute. As seen in ECG, P waves are abnormal. We cannot identify P wave properly. It shows altered atrial electrical activity. That is, and QRS complex is normal. It suggests arrhythmia of atrial origin. After that, baby was taken immediately on non-invasive ventilator. IV fluids were started, and IV adenosine was given at the dose of 0.1 mg per kg. One question for all the residents: what is the role of adenosine? What is the mechanism action? And what is the half-life of adenosine? How will you give adenosine? Anyone from the audience? Yes, Millie?
Adenosine causes AV block and it terminates the supraventricular tachycardia, and we give it by bolus method,
Flush method. And
what group of drug is it? Adenosine?
class 5 antiarrhythmic.
I think it's a selective beta blocker. No? No?
No.
Okay.
And what is half-life of adenosine? 5 to 6 seconds. Very good, Millie. This video demonstrates how to give adenosine in newborn. Adenosine should be always given under continuous ECG monitoring. Brachial or umbilical venous access is preferred. Adenosine is always given using stopcock with 2 syringes. From one syringe, adenosine is given, and immediately after that, from second syringe, NS bolus is given. It will provide immediate delivery of drug to the heart. Why is it done? Because of the very short half-life of only 6 seconds. This is real-time ECG change when we give adenosine in our patient. As you can see in the video, the rhythm is irregular and P wave is abnormal. Now the point when we give adenosine is AV blocker, it will slow down the ventricular beats. As it was given, the ventricular beats are prolonged and the underlying classical sawtooth appearance is seen, which is suggestive of atrial flutter. So adenosine was here. The role of adenosine is for diagnosis. It unmasks the atrial flutter immediately, and we have our diagnosis at 30 minutes of age. What is the next step? We have our diagnosis: baby with severe LV dysfunction, CRT was prolonged, metabolic acidosis, and clinically moderate respiratory distress. So baby is hemodynamically unstable. Should we go further for pharmacological treatment, or should we think of anything else? According to guideline, automated external defibrillator was used for rhythm correction. The left image is showing automated external defibrillator, and the right image is showing infant defibrillator pad. Size is 4 by 6 centimeter, and it is used to deliver shock in newborn. At 30 minutes of life, DC cardioversion was done using 1 joule per kg electrical shock. As you can see in the video, shock is being delivered to baby, and after giving shock, it immediately reverted the flutter to normal sinus rhythm. Here is one more video showing sinus rhythm achieved immediately after delivering shock. ECG before DC cardioversion showing irregular rhythm. After delivering shock, after DC cardioversion, the rhythm was regular, showing sinus rhythm. After restoration of sinus rhythm, IV amiodarone infusion was started at dose of 5 mic per kg per minute to prevent recurrence. As it was chronic atrial flutter, there was high chances of recurrence, and injection dobutamine infusion was started at dose of 10 mic per kg per minute to support left ventricle. Chest X-ray suggestive of mild ground glass opacity and low volume lung. It indicates respiratory distress syndrome seen in preterm newborns. Mild cardiomegaly seen with cardiothoracic ratio of 0.65. Further respiratory management, baby was taken on non-invasive ventilator for 2 days. Once parameter came down, baby was successfully weaned to room air on day of life 3 with stable oxygen saturation. Baby remained in sinus rhythm for next 2 days. Perfusion was improved. CR2 came to normal. Baby is out of shock. On echo, left ventricular ejection fraction increased from 10 to 15% to 35 to 40%. But Baby was having intermittent atrial flutter despite immunodiron infusion. Should we go for DC cardioversion? Yes, baby responded very well with first cardioversion, so we decided to do another DC cardioversion. On day of life 3, second DC cardioversion was done using 2 joule per kg. This time rhythm did not revert. After that, another shock was given at double dose of 4 joule per kg. It successfully restored the sinus rhythm. After the third shock, there was no recurrence of the atrial flutter noted. Nutritional management was taken care of simultaneously. Baby was kept NBM for first 2 days due to cardiogenic shock. Feeds were initiated, express breast milk was initiated on day of life 3 via NG, and it was progressively advanced. IV fluids were stopped gradually. As baby tolerated feeds well without any complication, breastfeeding was initiated on day of life 5. This slide is demonstrating day-wise progress in NICU. On day 1, ECG was showing atrial flutter. Within 30 minutes, DC cardioversion was done. After then, immunodiron infusion was started. Adenosine was used for only diagnosis purpose. Baby was taken on non-invasive ventilator. As circulation was poor, injection dobutamine was started. On day of life 2, rhythm was sinus. We continued the immunodiron infusion. Ventilation was non-invasive. As perfusion got better, we tapered the dobutamine dose. On day of life 3, we were experiencing sinus rhythm with intermittent atrial flutter. For this, second DC cardioversion was done. Here we did twice. After that, rhythm was sinus throughout, and circulation improved. Baby was hemodynamically stable. We stopped the dobutamine on day of life 3. On day of life 4, rhythm was sinus only. We continued the immunodiron infusion. Baby was successfully weaned from high flow nasal cannula to room air. Baby was hemodynamically stable. On day of life 5 and 6, rhythm was sinus. Ejection fraction improved from 10 to 20% to 50%. We shift injectable immunodiron to oral immunodiron. Baby was maintaining well on room air, and baby was hemodynamically stable. On day of life 6, we shifted baby to mother side. We kept baby in postnatal ward for 2 more days, and we discharged the baby on day of life 8. This is 12-lead ECG done before discharge, showing sinus rhythm. Echocardiogram done at discharge. It is showing increased ejection fraction, and the contractility was improved. On discharge, baby was weighing 2.4 kg. Baby is on exclusive breastfeeding. We started oral amiodarone, advised for 4 weeks. ECG was showing sinus rhythm, and echo was normal. In first follow-up, baby was gaining weight on exclusive breastfeeding. At this time, we stopped the oral amiodarone to see the response in the ECG rhythm, as rhythm was sinus only, echo was normal. And in second follow-up, that is 4 days back only, in Pediatric Cardiology OPD, baby gained weight adequately on exclusive breastfeeding, off medication, in sinus rhythm only, and echo was normal. The photo of baby at discharge at 4 weeks of age, and this is 10 weeks of age. It is a photo of 4 days back. Now I look to call upon stage Dr. Kanupriya ma'am. She is consultant pediatric cardiology. She'll brief us about neonatal tachyarrhythmia.
Thank you, Shalini. Good morning, respected dignitaries, seniors and colleagues. I'll briefly be discussing about neonatal arrhythmias. They are not uncommonly seen. The incidence is around 1 to 5% in all neonates, and they may occur in neonates with a normal heart or with those with a structural heart disease. They can present with variable clinical manifestations. Sometimes they are completely asymptomatic, being caught on a routine examination by pediatrician, and sometimes they present, as in our case, with overt heart failure and signs of poor perfusion. The classification is supraventricular and ventricular for tachycardia. Supraventricular is those that arise above the AV node grossly, and the ventricular tachycardias are those that arise below the AV node, that is from the ventricle. Supraventricular ventricular tachycardias can be further divided into re-entrant and automatic tachycardias. There is a third category also called triggered activity, but we do not see that in pediatrics, so not mentioned here. Reentrant tachycardias are most common tachycardias that can be seen in pediatrics and neonates, and they can be with an accessory pathway or without an accessory pathway. They are further classified into various types. Ventricular can be monomorphic or polymorphic VT, again always mostly associated with congenital heart disease, and ventricular tachycardias are not as common in the pediatric age group. So I'll specifically talk about neonatal atrial flutter because that was our case. This is an uncommon arrhythmia, the incidence being 1 in 50,000 live births, and it typically occurs in fetuses and newborn infants. If it is not present in the fetus, it usually presents within the first 2 days of life in a newborn infant, and it can present with signs and symptoms of overt heart failure, or can be asymptomatic also because it's sometimes a well-tolerated arrhythmia, and it can be potentially life-threatening if not recognized or treated on time. So this is a pictorial diagram of the heart showing the 4 chambers. The pictures in yellow are the conduction system of the heart. We can see there's an SA node, the AV node, his Purkinje system. The arrows in the white, here we can see that there is a circular movement or circuit formed in the right atrium, and this is actually the tachycardia circuit. What happens is that there's a trigger somewhere, and if there's an immature myocardium or there is a dilation of right atrium, some areas of the atrial myocardium will be refractory to impulses, some areas will be ready for depolarization. So it forms a circuit like this, and it goes on, and hence the atrial myocardium is continuously depolarized. This also sends the same impulses to left atrium, and as a result the atria beat continuously at very high rates. So etiology by and large is unknown, but there are certain factors which have been speculated to contribute to atrial flutter, which can be, as I mentioned, immature myocardium, and high right atrial pressures can be present in newborns because of a high pulmonary vascular resistance. There is no association between atrial flutter and structural congenital heart disease, as has been seen in various research studies. The mechanism I've already mentioned. It's a reentrant pathway located within the atrial wall, either the right or the left atrium, most often the right atrium. I would like to mention that AV block does not terminate atrial flutter because it's an atrial supraventricular tachycardia, and the AV node is not involved in the re-entry circuit of a atrial flutter. So adenosine cannot terminate flutter, because adenosine will act only on the AV node. So surface ECG is diagnostic. Atrial rates are very, very high, of the order of 300 to 400 or even higher. There is variable AV conduction, that is 2 to 1, 3 to 1, 4 to 1, by which I mean that atria are always beating higher than the ventricle, because AV node is normal in this circumstance, and it has a refractory period of its own. So it cannot conduct all the atrial impulses to the ventricle, and therefore there is a certain level of block. It will just conduct as soon as it recovers from its refractory period. So 2 to 1, 3 to 1, 4 to 1 or even higher blocks can be seen. Obtaining an echo can be useful to evaluate ventricular function, because a significant number of infants did have ventricular dysfunction because of AV dyssynchrony. So this is a typical ECG of atrial flutter. We can see the sawtooth pattern as we have always read in books. We can also see there is a certain level of AV dissociation. The QRS complexes. These are the QRS complexes. They are not evenly spaced, and these are the flutter waves. So you can see 3 flutter waves in between 2 QRS complexes. Here we can see just 1 wave, here again we can see. So it's a variable conduction. So classic sawtooth pattern. If flutter waves cannot be distinguished easily on ECG, like in our case, we were looking at the monitor mainly, then adenosine is useful at that time, because adenosine blocks the AV node, and as a result there is no ventricular activity. There are no impulses being conducted from the atria to the ventricle, and so for a brief period of 2-3 seconds the AV node will be blocked, and but the atria will continue beating because they are in flutter, and hence the flutter waves will be unmasked on ECG. So that's a good diagnostic tool in case we do not know whether it's really atrial flutter or not. Treatment of choice for this type of arrhythmia, especially in neonates, is synchronized DC cardioversion. at a dose of around 0.5 to 1 joules per kg. There is no consensus regarding which drug can be used for neonatal atrial flutter, but there are various that are being tried, but there is no one drug of choice for it. Recurrence of atrial flutter in neonates is rare and prophylactic medication is usually not required, but that we have seen for the flutters that are presenting in newborn period, that is within the first 2 days of life. Our patient was a chronic atrial flutter presenting from 28 weeks of gestation lasting for 3-4 weeks. So our patient was in the category of chronic atrial flutter and required more than actually just one DC shock. But 80% of the patients who receive DC shock with atrial flutter and relatively normal ventricular function will not require anything further, and not even prophylactic medications. For non-responders, amiodarone, flecainide, sotalol, as we see that the drugs that we gave in the mother also can be used. For our baby, we used amiodarone, which is a class 3 drug. It slows down all nodes and the depolarization in the myocardium as a whole. So prognosis is excellent in the absence of structural heart disease. Close to 80% infants do not require prophylactic medication, as I already mentioned. I would like to invite Dr. Khatri now to give us the takeaway points on this case.
Thanks, Dr. Kanupriya. So before coming to take home message, two very important things for resident doctors. To give adenosine, never hesitate to give adenosine. It's the safest drug. You are working in emergency, you are working in periphery, neonate in front of you, heart rate 220, 240, 250, 260. Give adenosine. 90% arrhythmia in neonate is supraventricular tachycardia, and they will respond to adenosine very well. Rhythm terminate in a 2 second, rhythm will terminate. Suppose a child is having 250 heart rate, neonate is having 250 heart rate with LV dysfunction. You can't refer the patient to the tertiary care center. First, at least you can give adenosine. Your nursery is equipped with all these drugs. Yeah, adenosine you give, 80% time rhythm revert to sinus because they are supraventricular tachycardia. No harm. If I get adenosine here, 6 second half-life, nothing will happen, no side effect. We give adenosine in the cath lab free 4 ampules to check the pulmonary pressure. It's a wonder drug. The problem is this, we are not aware how to give. Dr. Shalin demonstrated very nicely, push adenosine one side, push bolus from the other side, because we want it should reach the heart within 3 to 4 seconds, because half-life is 6 seconds. And you will find if you use adenosine carefully, you can save so many lives when you are working in the periphery. Do not refer initially. First, do the initial treatment. At least give adenosine. Second, do not hesitate to cardiovert the baby. It's the safest procedure. Okay. Western literature say you can do the cardioversion in the roadside also. You should always know how to do cardioversion. It's a very simple. If we keep pharmacotherapy in this patient for days, it will not respond. It will not respond. It will create the more problem. As flutter is chronic, it will not respond to DC cardioversion also. What we do in our equipped nursery, can you notice? In 30 minutes, we have the diagnosis, we have given the adenosine, we put the patient on non-invasive ventilation, and we are able to revert the rhythm back to the normal. Thanks providing such a high tertiary care nursery to us, where everything is available in a under roof, single, with a good neonatologist team. All DM residents are very well. They are thrilled to see how we use the adenosine and how we cardiovert the baby. And this is a life-saving. We cardiovert, it's a life-saving. Nothing will happen. The 30 seconds, the promptness of your work should be the key in this patient. This is the take-home message. Before coming to take-off message, I want to give pressure on the adenosine use, and do not hesitate to use cardioversion, because that is the only treatment. Suppose this child delivered at periphery with this poor LV function, refer to us. It will make child chronic flutter. So it's poor to respond to cardioversion also. We take the quick decision with the team. Me, Dr. Arjun, Dr. Saurabh discuss quickly with the help of DM resident. We cardiovert the patient within 30 minutes. So this is the take-home message. Fetal arrhythmia, though uncommon, can be life-threatening. We don't know the cause in first 2 lost baby. That may be the cause. That time we have no further investigation. Antenatal scans are good opportunity to diagnose these arrhythmia. Pick only by, because no complaint in the mother. Mother will say you what? मुझे palpitation हो रहा है? नहीं. सब कुछ तो fetus में हो रहा है. तो antenatal scan is there, very essential. Do not hesitate to do the antenatal scan. This is the only way we pick these arrhythmia. Multidisciplinary team approach is very important in the diagnosis and management of these arrhythmia. I, being a pediatric cardiologist, can't do anything with this patient until unless I have support of ops team and my neonatology team. It's a team effort. This the way we choose this case, because every team is ready to take care of this patient, and practically 30 minutes of life patient is asymptomatic. So prompt treatment is life saving. This is the key in this case. So my thanks to the management of Mahatma Gandhi Medical College and Hospital again to bring us in this prestigious institute. CCR review committee, they grilled us very thoroughly in last 2 days. Thank you, Dr. Jaiswal sir and Dr. Lalit Mohan sir, to provide us valuable guidelines. Collaborate departments, ops, for the patientness of Jaya madam. Obstetricians are not as cool as madam is there, what my experience. And Department of Neonatology with very energetic DM neonatologists. I wish us all the best to all DM candidates here, and future we have more cardiac cases because we are here now. So,